as far as the role of medication and the role of talk therapy, or what else might all be involved? What is your sort of strategy with this?
I'm happy to talk about that. And I will, by the way, talk about that when I talk about the experience I had treating someone with transverse myelitis and depression. And you will see the way in which medications and talk therapy work together. So I'll take the second question first, which is that we know from a number of large studies that antidepressants will work in depression, that talk therapy will work, but not if it's really severe depression. Really severe depression, talk therapy won't work, but if you combine medicine and talk therapy, it's far better than either one alone, okay? So what I'm saying is that the medicine is, you can take a tablet and sit at home and just be just as miserable. But if you take an antidepressant and you have depression, by the way, there's no street value, it's not addicting. If you're not depressed, it doesn't do anything for you. People aren't jonesing out on the street for Prozac, okay? It just doesn't work that way. But if you have depression and you take the medication, then it allows you then to make the kind of changes that you can make with talk therapy. But I will dispel some of the myths or preconceptions about how that actually goes. I'll describe for you what the treatment involved and how that went. But I am a believer that if it's mild depression, then certainly you can treat it with just talk therapy. But if it's severe depression, then physiological depression that's affecting the immune system, depression that's affecting the body, then you have to throw medications into the mix. But medications alone ain't going to do it. The issue about kids, and kids are more difficult, as I said before, like cough and pneumonia. In the younger kids, it's often, very often, in the majority of cases, you say, well, Johnny, you just picked up that desk and threw it out the window. Are you sad? And Johnny says, no, I'm not sad. I'm really pissed off right now, and I hate you, and I hate the world, and I can't believe this is going on. And so irritability is the equivalent symptom for kids. And it is not sadness, and often it sort of gets off the radar screen, and some of these kids get put on Ritalin because they're a behavior problem, and that's unfortunate because that's not it. So if essentially in kids, that's the big difference. Other than that, it often has some of the very same symptoms. And I think the point you bring up is a good one, which is to say the kinds of things that I see in patients with transverse myelitis are the chronic fatigue symptoms that won't go away, the concentration problems, and the sleep difficulties. And what happens is patients get sent to me with MS and TM very often when they're on Provigil for the fatigue, but they're not sleeping, so then they're put on Valium at night to help them sleep. And because they're on the Valium and the Provigil, they're not thinking too clearly, so someone thought they'd add something to improve their concentration. So now they're being treated with 3 or 4 drugs, none of which are antidepressants, none of which are treating what the problem is. It's like taking Tylenol for pneumonia. Yeah, it'll bring your fever down, but you're not going to get rid of the pneumonia that way. So often it's these physiological symptoms that people with TM have, as well as the fact that when someone comes to me and says, it feels like I've died already and I'm still here on this planet, that's a pretty good indicator. And that feeling of I just can't get back to my old self. And that's the one question that I ask significant others, caregivers, when they come into the office. I say, is this the man you married 10 years ago? That is not the man I married 10 years ago. He is a different person. He's a changed man since the transverse myelitis. That's pretty telling to me because people don't go through personality complete changes. I mean, the Dr. and Jekyll, Mr. Hyde thing tends to be something that actually Dr. Jekyll and Mr. Hyde was written by a gentleman who suffered from bipolar disorder. So it tends to be more a mood-related thing that when people's personality changes, you should immediately think that this is something due to depression. So, what I can tell you is you're not supposed to be able to diagnose it. You're not supposed to be able to tell the difference between TM and MS and ADEM. But if you're worried and you know that your legs aren't working right or you haven't peed in 3 days, there's something wrong there, and you go to see the doctor. So if you're worried that this may be depression in me, my loved one, my child, then you should just go get it checked out, because maybe it's demoralization, but maybe it's something that will dramatically affect not only your life and your loved ones' lives, but it will probably also affect your illness and the course of your illness.
I'm going to ask that you ask your questions with the microphone because you're having a hard time picking this up on the tape. So have patience with me.
You mentioned that stress can worsen MS or TM.
Yeah.
Do you think that stress can make someone more vulnerable to having an attack of TM, for example, in the first place?
Yeah, I get asked, you're the second person in 24 hours to ask me that question. And I would say, okay, so you're asking me to speculate. So I'm going to give you my speculation. I tried to differentiate when I showed you data, what the data was versus what I was speculating about. Now you're asking me to speculate. And my guess is, no, that probably isn't. There has to be 5 things that all go wrong simultaneously to get TM. You have to have been born with a predisposition to have your immune system just go like gangbusters when you suddenly got a small breakdown in your blood-brain barrier and a few of those military white blood cells got across the line, and then they saw something that looked like that bacteria back there, and they said, kill it, and it just happened to be your spinal cord. And when all of those things went wrong at the same time, suddenly you had transverse myelitis. It's a rare thing for all of those stars to align. If you hadn't had the infection, if you hadn't have, rolled over in a car, if you hadn't have had some, various triggers, you wouldn't have gotten it. We rarely see it in families. Even people who have, in family histories of MS, we rarely see TM clustering in families. So all of these things have to align, and I think depression causing it is not a huge contribution, not a big contribution, but I think once it gets going, then I think it does play a role. And then I get worried about it, and then I treat it. I try to make sure. And the problem is, by the way, that people often come to me and they say, yeah, well, Dr. Kaplan, yes, I'm depressed. You'd be depressed too. That's the way they dismiss it. You'd be depressed too if your wife walked out on you. I say, is that when it started? Yeah, it started when my wife walked out on me. And I call the wife in from the waiting room and say, can you tell me why or I call her on the phone. She walked out on him, right? So I call her on the phone, and I say, why'd you leave this guy? Well, he was sitting on the couch all day. He was abusive. He wasn't the man I married. He's turned to alcohol. He was depressed far before that happened. But when something happens, we have to have an explanation. It's not just a bunch of winds circling around in a pressure zone. It's Charlie, okay? We have to have an explanation, something we can hold on to. And so when something happens and we get depressed, we all have stressors in our life, and we all have something we can point to. And it's not always the stressor that did it. A lot of times the stressor can make it worse, but it's not always the stressor that did it, even though it always looks like it.
I'm an occupational therapist working in an inpatient rehab facility. When we're
Great.
having people come to our facility, it's the first time that they've had this major change to their lives.
Sure.
And they haven't had the opportunity to be able to cope with that change.
Yep.
Do you have suggestions for us? Because as occupational and physical therapists, a lot of times we are dealing with these intimate discussions during intimate, self-care and
Right.
things that they're going through, and they don't have medicines that have taken effect yet.
Right.
They're here maybe for sometimes 2 weeks, sometimes 8 weeks, sometimes longer, shorter.
Sure.
What suggestions do you have for us to be able to help them to begin this coping process to also be as effective as possible in their rehab process?
So again, that goes back to so I would initially probably start with saying, remember what we talked about, demoralization. Find coping strategies. And by the way, I'm a huge fan of OT. And just to put a plug in for OT is a lot of times it's the structure. And I tell my patients, I woke up this morning and I didn't want to get out of bed. I was just too tired. And I thought, this is too tough for me today. I'm just going to lie here in bed. And some days I want to do that. And I still go in because if I laid there in bed, I'm definitely going to be more depressed at the end of the day. I may be more exhausted at the end of the day if I go into work. And OT is really good about helping people structure their time and get going and organize themselves, and OT provide me the information I need about how people are actually working. It's sort of the road testing of how you're doing is what OT does. So I'm a big fan. And in terms of the question you asked, initially I think, when someone loses their spouse of 40 years and they say, how could she have left me? She smoked. I wish she'd not smoked. That's a common reaction. The reaction, she left me because I'm a miserable person and I'm being punished. That's worrisome to me, and I would watch that closely, but I would probably help someone through, as you assume it's demoralization probably, for the initial phases and see how it goes. The patient I'm going to actually present tomorrow, initially, days after he was extubated, the tube was taken out, his breathing tube was taken out, within a few days he was miserable and depressed, and he actually requested someone to talk to about that. And the team of psychiatrists came in, and they said, this could just be because he just had this terrible news, or it could be because he just got a lot of steroids, or it could be depression, and we think that we should follow it. And then if he's still depressed and still not doing, occupational therapy and rehab and stuff like that, a month later, 2 months later. And one of the telling signs, by the way, if you're worried about your loved one and you think maybe they're depressed, one thing that is, so when I talk to the significant others, I always ask, is this the person you married? When I talk to people and they describe, as Sandy's actually going to have people describe in just a minute, their experience, and not only do they describe their experience, they describe it as though they're going through it right there in the office, as though it happened yesterday, okay? They're living with that ongoing shock and pain, and sometimes it's 10 years ago, okay? Sometimes it's a year ago. But if someone describes that level of pain, suffering, and anguish, and it happened a while ago, that's usually a pretty good sign it's depression. Does that help? Did I come close to answering your question? Okay. Yeah. Right.
They're not at that point yet.
Right. Well, so I agree. I think oftentimes people aren't there yet. You're seeing them in the most acute phases, but you can still say, look, you're going through a hard time. Be as supportive as you can, and then say, but if you talk to your physician. If you need a referral, you can go get checked out and the like. And I will just tell you that. The one thing I will tell you, that suicide rate being really high over 50 years, the U.S. Air Force actually decided that since 1 in 4 people in the Air Force were dying because of suicide, they put together a suicide prevention program in the Air Force, and they had people like you, people like chaplains, people like generals being responsible for screening the people under them for depression, and if they screened someone was worried about them, they got referred. And in the military, if they say you go get checked out, you go get checked out. What percentage decrease in the rate of suicide do you think they had? That's a good guess. That's optimist, and it was 90% decrease in the rate of suicide. So it takes a village. It takes all of us. The loved ones, the patient, the occupational therapists, the physical therapists. It takes everybody to handle these things. You can't just say, oh well, we're not going to worry about the fact that you haven't peed in 3 days. Okay, you got to take care of all of it. It's all going on at the same time.
Are there any other questions for Adam?
First, I have just a minor one. You said lesions secrete something to the brain. What is the name of the thing that's secreted from the spinal cord to the brain?
Yeah, so it's actually the activation of the immune system causes these cells, these immune cells, to release something called a cytokine. And a cytokine is the same thing to 2 immune cells that a neurotransmitter is to 2 neurons. It's what allows them to communicate with one another. And I'll get into all the details tomorrow.
Why do people with TM have a much higher incidence of suicide? Or was it suicide or depression than multiple sclerosis patients?
Why do TM patients have a higher rate of suicide than MS patients? That's a very good question. I wish I could tell you the definitive reason. I think that part of the reason is that with TM, it's more isolating. I mean, there's a lot of, when people come to this conference, they often meet other patients with TM for the first time in their lives. And I mean, I will tell you that people who have committed suicide, unfortunately, the majority of them, came for an initial consultation with Doug, then went out, didn't follow up, and we hear that they committed suicide. And it's sort of the isolation, I think, that plays a role, but I also think that it's a really bad depression. I think that TM, more than MS, remember, our data says twice the rate of depression in TM in cross-section in terms of its incidence as in MS. It's the Olympic triathlete, it's the winner. So I think that probably plays a big role in it. But I mean, I don't have a great explanation why it looks like it's so much higher, except that I would say, to be fair, that there's no other center in the world that sees the number of patients we see. So these are the best numbers we have, because no one else has looked at 500 patients with TM. However, the patients that come to see us are not the patients who had just a little tingling in their toes and went to sleep and slept it off, right? There's lots of cases out there of people who never even knew they had TM. And there's lots of cases of TM that isn't bad enough to bring you from Iran to see us at the Johns Hopkins Transverse Myelitis Center. So I think we see the more severe cases, at Hopkins. And I suspect there's many cases out there of people who are much less severely affected. But having said that, I think there's still a dramatically high rate.
Adam just raised an issue that, just out of curiosity, I would be interested in seeing. How many of you with transverse myelitis are here meeting a person with transverse myelitis for the first time?
Wow.
So there are a lot of you. I mean, take a look around the room. Keep your hands up. I mean, this is one of the reasons why
that's 80% easy.
This is so important for us to make this opportunity available for you. Now, the really disappointing thing for me about seeing that is, and it goes to the issue you raised about support groups, our hope and our goal is to try to get as many local support groups going as possible so that we don't have that many of you raising your hands. And I will say that if you don't have a support group in your state, and we have a support group in the state of Ohio, and Ohio is a fairly large state geographically, and yet we figure out a way to get people to Columbus, Ohio, which is sort of in the center of the state, once every 3 or 4 months. It's possible to do this. If you don't have a support group in your state, it's not a tremendous amount of work, because the first thing we do is try to find a whole bunch of other people to help you, and you're going to create a tremendous benefit for others. And here's the big secret about support groups. The person who benefits the most from a support group is the one who's coordinating it. Honestly, that's really the way it works. So if you're interested in doing that, find me. My telephone number's on the main page of the website. I'm not hard to find. Somebody here had a question.
I actually just wanted to clarify something you said earlier. You were
Sure.
talking about the statistics of the suicide rate of the people who had come through Hopkins.
Yeah.
And I was just wondering if you could repeat that again, because you said it so fast that I wasn't sure I understood you correctly. So something like 60% of the people that have-
60%, okay, right. Thank you for asking me to clarify. My wife eats a lot faster than I do, but I talk a lot faster than she does. And I don't want you to misunderstand that. It is not that 60% of people with TM commit suicide. It is 60% of the deaths, and luckily, you shouldn't die from TM. It happens, but you shouldn't. Because even if you're in Jim's position, if you're not sent, there are cases that break my heart of people who were misdiagnosed, sent out of the emergency room, and then go into respiratory failure and die. That is an iatrogenic effect. As far as that's medicine's fault. Okay, that they dropped the ball, and that's why we need to make sure everybody's educated in the emergency rooms about what this is. But so you shouldn't die. when you're, relatively young, and which is often the onset is peak in the 20s and 30s, you shouldn't be dying. And of the people who die, 60% of the deaths are from suicide. And that's the same thing, Montel Williams, pick up his book, Climbing Higher. He's a guy, he snowboards, he's, earns millions of dollars a year. He shouldn't be dying. He's got MS. He has a lot of pain from his MS, but he shouldn't be dying. But that didn't mean he didn't take out his gun, spin the chamber, sit in the closet for several hours. That doesn't mean he didn't throw himself into traffic in the circle in New York City by his office, hoping that the guy would run over him. Okay, so Montel shouldn't be dead, and if he had died, it would have been because of the depression. And he's very open about it. I'm not sort of speaking some private privileged information. Read the book, and it's all there. So thank you for clarifying. It's 60% of the deaths, and people, shouldn't be dying, but when they do, unfortunately, the majority of deaths are due to suicide.
We know that we have a large contingent from Maryland who are here at the symposium just because it's in Baltimore. I'd like to introduce Alan and Kelly Connor. Please raise your hand so everybody can see you. These are the leaders of our support group in Maryland, and if you have not yet contacted the Connors and are interested in getting involved in the Maryland support group, please do so sometime over the weekend.
And also, I think it's fair to say that they are wonderful cooks, and they have this wonderful cookbook that they have put together to raise money for the TMA. And you can take a look at it out there. I got to plug that. That they have this lovely cookbook with fabulous recipes, and 100% of that money, 100%, yes? 100%, except what I take from this plug, goes to the TMA.
Thank you, Adam.
Sure.
Hi, thank you so much for your talk. It's very interesting.
Thank you.
I'm a psychologist in New York, and I'm sort of sitting here thinking about how amazing it is that you guys have such a great team where you've really integrated psychiatry and psychology into treatment.
Yeah.
It's likely, and frustratingly so, not that way in many other places, particularly since there aren't other centers like the ones at Hopkins. I'm just curious if I know there's a lot of support groups and that there's a network for that. Is there a network that people can, find a psychologist, find a psychiatrist in their area that has knowledge about TM, or is that something that you guys are pursuing?
Yeah, well, 4 ideas come to mind with the points that you bring up that are very important. The first is that Stephen Wagner is going to talk to us tomorrow about how you can, I believe he's going to tell us, because he has taught me a lot about this, how to teach people, patients, how to advocate for themselves, how to take control of their treatment. And if their doctors aren't talking, you say, can you please call my neurologist? I'm not sure if he wants me on that medicine. And I think he'll illuminate that aspect. It amazes me. It amazes me that doctors don't talk to one another. And at Hopkins, I will say that Doug set the standard. He's the one who started the Transverse Myelitis Center and integrated, people like Barbara de la Tour, the world's greatest physiatrist in physical medicine and rehabilitation, and got a team together of urologists, psychiatrists, the whole 9 yards. And everybody has to talk together, because if they're not, the person who's suffering is the patient. And that's just a crucial part. I needed to know from Barbara de la Tour something she told me about a patient she was seeing that day, that there was some return of function in her feet, which had implications for me helping her with the sexual questions she had, okay, in terms of the feeling, and was there any possibility that there would be some increased feeling and return. I mean, that was important information, and I don't understand how physicians can do it any other way, but yes, they should be talking. If they're not, then they can. But the other thing is, people always say, well, where can I go to get someone? And I try to tell them the thing that will help is you have a doctor right now, presumably. I mean, I don't think anybody's here who has not seen a neurologist, because to get the diagnosis, you came here. And one thing that you can do is that you can go to the neurologist and say, look, I think I'm sort of bummed out. Is there someone who you can recommend I see? And you're creating a situation where it's more likely that that neurologist is going to know, work with, have a congenial relationship, and will communicate with the person he or she uses. So that's the place to start, for that reason that you mentioned. There are websites. If you put in DART, D-A-R-T, and NIMH, you get to this website that's a clearinghouse of referral sources and the like. But I really think, more important than that, you start with talking to your neurologist for the reasons that you brought up, or your primary care practitioner. The most common context in which you see psychiatric illnesses, as I showed you before, are neurological diseases: Parkinson's disease, Alzheimer's, MS. So these neurologists, they're not working completely in their jobs if they don't recognize the psychiatric aspects and therefore have psychologists and psychiatrists who they refer people to. Long answer to your question.
From the research that you've done, it's fairly obvious that depression is a significant problem for the TM population. And I just wanted to speak for a minute about something that Jesse Daninger and I have learned doing research that we've been engaged in for the last 7.5 years. And we'll be talking a lot more about this on Saturday morning, but I think it's illustrative of a significant problem that exists. We began to administer a survey in 1997 when we sent out the first newsletter, and we have continued to administer that survey up until this past May. Do any of you remember filling out the Transverse Myelitis Association survey? It was about 30-some questions. Well, we ended up with 815 respondents to that survey, which is just, as you know, an enormously high number of
Phenomenal.
people.
That's why, again, it is only through the cooperation and the fact that patients such as these are willing to teach the doctors and participate in the studies that we're going to, crack the nut of what's causing it.
But what was really fascinating about this research to me was that we asked 3 questions about symptoms. We asked, what were your onset symptoms? What were your most severe symptoms? And what are your current symptoms? So we gave people the opportunity 3 different times to describe, and these were entirely open-ended questions. There were no check boxes, so a person could sit with those blank lines and describe their symptoms to us in their words, however they wanted to do so. And out of 815 respondents, I'm going to guess, because I don't remember the number, I don't think 10 people identified depression as a symptom of their TM. Out of 815, we know that's just, whether you had it at onset, which maybe not have been likely that somebody would have identified it then, but what were your most severe and what are your current symptoms for 10 or so people to identify depression as a symptom is way underreported. The other really fascinating issue to me was it was probably about 10 people who identified sexual dysfunction as a problem. And we know that sexual dysfunction is a problem for a lot higher than 10 people out of 815. And what that says to me is there are problems that people have, and it was a open-ended survey. People were able to identify whatever they wanted to identify to write in that as their responses. The fact that people aren't expressing that, to me at least, reflects some reticence to be open about that. And, and that's a problem, because I don't think it's just a lack of wanting to be open about it to the Transverse Myelitis Association. I think it's a concern, at least that I have, about whether you have a reticence to talk about these issues with your physician, who's the person who really needs to hear about the fact that you have these symptoms. And so that you didn't tell us about it, okay, we'll live. But you need to be talking to your doctor about these problems, because we know more than 10 people out of 815 have sexual dysfunction and depression.
Yeah, I mean, it sort of reminds me of the fact that in all of these earlier studies, when they ascertained whether or not the medications people are given cause sexual side effects, they say, so, are you having any side effects? And people say no. But if you say, and are you having, difficulties getting and maintaining an erection? Well, yeah. So it's only on direct questioning do people endorse those things. Ever since Viagra was invented, people are coming forward a little bit more and sort of saying, oh, by the way, on the sly. So the point I would just make about that is that the reason why there is nothing I enjoy treating more than depression is because there is nothing that has such a tremendous impact. You can't give me another disease in the entire book of medicine that has as much of an impact on a patient and their loved ones that you can get them 100% well. And getting people 100% well is a great thing. And so the most important message, if you get nothing else from what I've said here today, is that depression is treatable. And this is one of the most treatable aspects of transverse myelitis is depression. So we have the Viagra for depression. I mean, we can treat it, but you have to be willing to consider it.
Getting back to suicide, I have a question about, is it possible that some of these antidepressant medications actually increase the rate of suicide, gives the patients more energy to then entertain such an act? And what do you do about that when
Right.
that comes up?
Thanks, Frank. Appreciate that. And what Frank's talking about is the controversy over the use of antidepressants in kids, because that has now sort of spread. There is this Oliver Stone-ish phenomenon in England. In England, they think all of the physicians are in the pockets of the pharmaceutical companies. Literally, I can give you articles that basically say this. And therefore, they feel that all of the studies done on kids with depression had underreported the rates of suicidal thinking and the like. By the way, in all of that, not a single kid died from suicide in any of the studies you've heard about. But there was an increase, statistically significant increase in the rates of suicidal thinking or behavior in kids who were on Paxil, so don't use Paxil for depression because there's no proof that it works. But by the way, there is lots of proof that there is not an increased rate in suicide from taking FDA-approved medications. Prozac is FDA-approved to use in kids, and there's no question that it helps depression, and helping depression decreases the rate of suicide. Now, there's no question, though, that the medicines aren't enough. That's not going to do it. And I think part of the problem is that, yes, I have seen people put on antidepressants, and it turned out that they had bipolar disorder, and they got manic, and then they became, impulsive, and that put them at greater risk. So, to some extent, I would just say, if the medicine isn't helping, or it seems to be hurting, you definitely want to go to an expert and make sure that they can take a look and see what's going on. Because I often encourage my colleagues to take a first pass if they pick up depression and try to treat it. But so essentially, all of the evidence that we have suggests that there is not an increased rate of suicide. And in fact, we have evidence that have said, and this is sort of a subtlety, at the tail end of that suicide rate, it had gone up for the middle 3 decades in this century. And sort of towards the tail end, it starts to actually come down. And there is correlations between the increased rate of antidepressants among the elderly correlates very nicely with the decreased rates of suicide among the elderly. And the fact that there is not a decreased rate of suicide among kids correlates with the fact that there's not many antidepressants being used in kids. Now, having said that, I'm not endorsing going out and using Paxil in kids, but I will tell you that any drug is a toxin. Anybody who's on any medicine knows that there are side effects, and from any treatment for that matter. And so you need to be monitored on any of these medicines. I don't care if it's steroids or what have you. But essentially there is no question in my experience, and I've treated thousands of patients, that when they're depressed, that's when they're going to hurt themselves, and you can get them with treatment, often involving antidepressants, all the way well, in a way that I can't get some people with severe depression well without it.
Adam, thank you so much.
Thank you. Thanks, Sam.
The discussion about onset, I thought we would do that instead of having dinner. Is that all right with everybody? We're not going to have that discussion, obviously, and I'd actually rather see you all have a few extra minutes before dinner tonight to go to your rooms and do whatever you need to do for yourselves and relax for a few minutes. Let me tell you what my thinking was about that discussion, just so that you have some idea about the incredible discussion you just missed. And it's an important thing, and I think it really, at some point in time, it is something that we really do want to get before the physicians, because they're aware that we do really need to educate them about transverse myelitis. There is just such a tremendous range of variability in people's onset experiences in terms of what were the preceding conditions before they got TM. For a significant number of people, it's idiopathic. There was no preceding anything. But just from my anecdotal experience, it is amazing to me how many sorts of things happen to people before they get a TM diagnosis. I have been amazed at how many people have had a trauma that triggered some kind of an inflammatory attack in a person. There was no structural damage done to the person. There was a trauma, there was nothing else that happened with this person, and they end up with a TM diagnosis from an inflammation that's seen on an MRI. The physicians need to hear these sorts of experiences, because I don't believe they get the total range, because there really aren't that many physicians. Johns Hopkins sees a lot of TM cases. Mayo sees a lot of TM cases. Cleveland Clinic sees probably a disproportionately high number of cases. But there are not that many medical facilities around the country that see enough TM cases that they're seeing that range of variability. So my thought was, have the discussion, let the doctors hear about that, and maybe get some ideas to be thinking a little broader than how they're thinking about what happens to people during onset, from acute and dramatic to slowly progressing, to people who have these lingering months and months and months of onset. They don't ever get an MS diagnosis. Something's going on with them. But at any rate, that was the idea. That's what we're not doing. We'll see you all at dinner, 6:15. Go to the tables. There's going to be a keynote speaker, and then after that, we'll have dinner. Thank you.